Good evening, everyone. So I'm presenting the case of an OCT guided optimization of an under-deployed stent in the distal left main ostial LAD, and as well, this case had a aneurysm in the mid LAD stented segment, and we covered it with an aneurysm with a covered stent, this aneurysmal segment. So just a brief background. The patient is a 73-year-old male who is not a diabetic, not a hypertensive, and this gentleman had unstable angina, so he underwent PTC with stenting to LAD at a peripheral center using two drug-eluting stents. And 3 months after the index procedure, he again had recurrence of his chest pain, and then he underwent angiogram again at the same center, where it was seen that this gentleman had developed an aneurysm in the mid LAD at the stented site, and he was referred to our center for coronary artery bypass graft. I had seen the angiogram of this gentleman done outside. To me, it looked like a pretty straightforward case. So I discussed about the CABG vis-a-vis the stenting options for this patient, and the patient himself was a retired cardiac perfusionist, and he was very reluctant for surgery. So he was always open that if this can be done percutaneously, why not? So his angiogram one done outside it showed it was a left dominant circulation. His right coronary artery was a small coronary artery. It was normal, and these are the shots which you are seeing, which are done at my center. We started with a guide only, so it was a 7 French guide. I had used the right ulnar artery because radial was a bit feeble in this patient, so it was a 7 French right ulnar, and it was a JL 7 French, and in the areocranial projection we could see a small fusiform aneurysm in the mid LAD stented segment, and if we see the areocaudal projection, we could see the stent was which we could see was starting from the distal left main, and it was going into the mid LAD, and some studs of the ostial LAD stent, they were even covering the ostium of the dominant circumflex. And in the yellow caudal projection, again we can very clearly see we could see that there's a small aneurysm in the mid LAD stented segment, and with a left dominant circulation, and there was a lesion even in a OM, which was also a pretty tight lesion, which was not even tackled at even 3 months down the lane. So we thought we'll manage it at a later stage, and we will just fix this aneurysm with a covered stent. So the plan was a PCI to this segment, and so to me it looked like a pretty simple case. So I just crossed the lesion with a BMW wire, but to my surprise, I couldn't enter into the LAD from this left main with a 2 mm balloon first. Then I downsized it to 1.5 mm. I failed. Then I took 1.25. I again failed. So I thought that my wire is going abluminally through the stent studs. So I took a second BMW wire now with a bigger loop, so that I am going through the lumen. So I had the second wire. I again tried the different balloon sizes, but I failed. Then I took a third BMW wire, now again with a further bigger loop, so that I enter through the main lumen rather than through the stent studs. So at this point of time, I had 3 wires into the distal LAD, and I was still unable to cross with a 1.5 mm balloon. But with the 3 wires in the LAD, I deeply engaged my guide, and I took a 1.2 mm balloon, 1.2 into 8 mm balloon, and I could enter into the LAD. And so I dilated the struts to make a new entry into the LAD. So I dilated it with a 1.2 into 8 mm balloon. Then I upsized it to 1.5, then 2, then 2.5, and then 3, and then 3.5 mm. So I periodically up titrated the sizes, and ultimately we dilated this new entry into the LAD with a 3.5 mm balloon. And once I had done the dilatation with a 3.5 mm balloon. Now I could easily take my OCT catheter into the LAD. So these were the now OCT pullback catheters which were taken to really see what was happening at the aneurysm site as well as into the distal left main ostial LAD site. So this was the OCT pullback of this patient. I think if we really can see the distal at the distal edge, we can see the some heterogeneous ISR was there. A stent looked pretty well expanded at the distal edge. This was a huge aneurysm. This was a huge fusiform aneurysm in the mid LAD stented segment with the stent studs we could easily see hanging into the aneurysm side, and then coming proximally into the LAD again, stent looked pretty well deployed. And now once we come at the left main bifurcation, we could see again stent was under deployed, which was not and I think in the next projection as well. So this is the summary of the OCT. There was a heterogeneous ISR at the distal edge, but the stent looked well deployed, and the distal reference vessel diameter was around 2.6 millimeter or so. The lumen area was okay, and coming on to the aneurysm in the down and on the lower pictures, we could see a huge fusiform aneurysm which was seen arising from this LAD from the stented segment, and the stent studs were seen hanging into the aneurysm, and aneurysm was much bigger in size compared with the LAD itself. And coming on to the proximally, we could see in the left main, the stent was under deployed, and we could see some thrombus as well in the distal left main. So once we had done an OCT, then we took a 3.5 into 26 mm graft master, which was deployed at a high 18 atmospheres, and immediately after the deployment, we could see that the aneurysm has knocked off, but the distal edge was not looking very healthy. So a 3 into 18 mm stent was deployed for the distal edge, and with the same balloon, we dilated the left main stent as well, and so this was how it looked like. And then because I had made the new entry into the LAD, so another 4 into 28 mm stent was deployed from the left main into which was going into the covered stent. And after that, the stent the result looked okay, and then again an OCT pullback was taken, and now this OCT pullback, if we see really the stent looked absolutely well deployed, and this is the distal stent, and now we'll start seeing so this is now where the covered stent has come. So we couldn't see any now, absolutely no aneurysm is visible, and because it's a covered stent, so none of the tissue is visible beyond the covered stent. And coming proximally into the proximal LAD, again I think there are 3 layers of stent now at this point of time, and the stent was again very well deployed, and if we see the expansion in both the halves, it was 88% vis-a-vis 97%, and once coming into the left main, again we could see the luminal area was exceptionally great, although stent still looked a bit deformed. So the stent expansion was excellent. Distal edge was fine. There was no edge dissection. There was no ISR which was visible at this point of time, and even the proximally, although because new luminal area was very good. So I think this was an exception acceptable result, but still I dilated the left main and the ostial LAD part. It was dilated with a 4.5 mm balloon, and this was the, I think, final result we could achieve in this patient. So I think, and I did this procedure around 10 months back, and I think the patient is clinically doing well. And so I think we keep on seeing coronary artery aneurysms, especially post our coronary interventions. I think, and so this was just a case to highlight, I think, number of coronary artery aneurysms which are probably drug induced, which are iatrogenic. So I think this is one way I think we can address these, because I think priorly we used to refer these patients for a coronary artery bypass grafting, but with I think covered stents, and especially with the usage of imaging like IVUS or OCT, I think they make the things a lot more clearer to us, so that we can achieve I think good end results.
So it was a wonderful case actually.
Thank you, sir.
So it was a very tedious one to start with. Once your wire was going beneath the stent strut, so three wires, and still you are not entering with a very small caliber balloon. You were finding it difficult. Only thing which I think would have been done slightly different at that point. You know, so once we do that, we try to make a with the distal edge of the wire touching there while we're trying to enter into the stented segment, we try to create a loop of the wire, and then with that loop enter that. So loop cannot go beneath the stent strut. That is one thing which we can try differently. If we, because you had three wires and all the wires have gone through, so there is some deformity or it's quite under expanded there. That is very clear. But still, in the end, you managed it quite well. Another point was that covered stent. So obviously you have to have a very good dilatations, and in any case, if you are going through the stented segment, you had three wires, but you have to have a buddy wire at times. So I think taking a covered stent is a bulky stent. So taking a bulky stent with one wire, usually one faces a lot of difficulty, and especially through a stented tube. It's a tube. And so in that case, one should always keep in mind, if there is a single wire, have a buddy wire and then take the covered stent down, because this is an elective situation. Mostly we use covered stents in a urgent situation where there is a perforation or something. So in that case, if the time is wasted while covered stent is not going down at the point where the perforation has happened, we waste a lot of time. So once it happens, straight think of another buddy wire in place and then try to take the covered stent, rather than trying with a single wire and then getting in there. So other than this, I think it's wonderfully done, Karun. Wonderfully done.
Thank you, sir. So,
Yeah,
because my only, I think the thought, I used three wires, and the second wire had a bigger curve than the first wire. I thought I tried to make it like a knuckle, but maybe still, because it was a BMW wire only. Maybe to your experience, sir, any other wire do you feel maybe might have made the difference? Because we are most comfortable with the universal, honestly. So the second wire had a bigger curve. The third had the bigger than the second, but still, unfortunately, maybe on that fine day I was entering abdominally only, or there was some issue at the proximal edge of the stent. But unfortunately, because I could take my OCT catheter only once I had dilated with a 3.5 mm, then probably my assessment of that ostial LED stent is I think is already compromised. So unfortunately, because nothing was crossing, so taking OCT at that point in time was absolutely impossible.
Yeah, one tip while making a knuckle or loop at the end of the wire while entering into a deformed stented segment. So at times, if your guide is, if all the three wires went into that direction, so that means guide is pointing towards that direction only. Yeah. You may have to think of changing the guide also. That is number one. Two, while you start wiring and reach a proximal segment of the stent with a bigger curve at the end, you stop there and try to make that as the wire is facing some resistance, then the knuckle happens, then the loop happens.
Right.
So keep on trying that for some time, maybe 5-7 minutes, and then if that loop becomes, then just push. So give it some more time there. But still, I agree, at times we do not make a knuckle at there. So it requires a slight bit of more patience. And another tip is that you can change the curve of the guide so that it starts looking differently.
So if you have seen, I have used GL. I used XP to begin with, but my XP was favoring circumflex, so I changed over to GL. So it was an FL because I thought probably it will be more favoring LED. So it was a GL 7 French.
But yes, it is very well done. Only thing which also comes to my mind is as to increase the discussion on this case. So it was 3 months post angioplasty somewhere else, right?
Yeah.
So usually once the patient lands up with such an early aneurysm, one should properly rule out the infective
Yeah,
pathology.
agreed. So that was never the case. There was no, because if it would have been a septic aneurysm patient,
Must be
I have
toxic.
seen that they are very toxic. They're very toxic patients generally, and then leukocytosis. So absolutely, patient otherwise came walking to me in my OPD, and again now it's a 10 months of clinical follow-up, absolutely pain-free, no issues at all. So, but definitely yes, aneurysms. I have seen. I think a patient had multiple times recurrent stent thrombosis, and around 1 month later he came to me with large aneurysms in the LAD, and then that was a septic aneurysm. So I think when probably an urgent surgery is the only way of proceeding. But this patient, we got a PCT done, TLC was normal, there was absolutely no evidence of sepsis. So then I think we have seen aneurysm as early as 1 month as well, probably with maybe with some especially with the drug-eluting stents.
Right. So I'm just saying. So I think you
Yeah,
must have done all the homework.
right, sir.
But this is highly important to look at
Yeah,
the cultures and WPCs and the procals and CRPs. Very, very important. Yes, usually the patients are toxic, but it could be indolent infection, slowly growing, and the patient may not be that toxic, maybe mild fever in third or fourth day. So these things are also known. But
absolutely.
but overall, a very well managed case, and hopefully this patient should do well. Only thing is now patient has multiple layers of stents. Be very
Agree.
aggressive on the dual antiplatelets, or even the higher dosages for dual antiplatelets. That's how I would put it.
Agreed, sir. Absolutely agreed. Thank
Yeah.
you very much. Thank you, sir.